Bueno, muy buenas tardes. Esta es la reunión de la División de Anestesia de la Pontificia Universidad Católica, en una reunión extraordinaria en que vamos a tener, es una reunión histórica porque vamos a tener a un invitado de una categoría mundial, que es el doctor David Chestnut. Esta conferencia va a estar transmitida por el canal de YouTube, como están todos ustedes conectados, en la cual usted puede tener interacción con nosotros en el chat que tiene disponible y donde ustedes podrán ir haciendo sus comentarios o bien sus preguntas para que posteriormente el doctor Chestnut, si es necesario, las pueda contestar. Entonces quiero hacerles una pequeña introducción del doctor Chestnut. Él es profesor de anestesiología del Centro Médico de la Universidad de Vanderbilt actualmente, y es editor en jefe del libro Chestnut Obstetric Anesthesia, Principles and Practice. La sexta edición de este libro se publicó en el año 2019 y ha sido traducido a 4 idiomas además del inglés. Finalmente ya ha sido traducida al español. Anteriormente, el doctor Chestnut fue jefe de departamento de anestesiología de la Universidad de Alabama en Birmingham, y luego fue decano asociado de la Facultad de Medicina y Salud Pública de la Universidad de Wisconsin. Perdón. Como les decía, él fue decano asociado de la Facultad de Medicina y Salud Pública de la Universidad de Wisconsin, antes de irse a Vanderbilt el año 2014. El doctor Chestnut ha publicado más de 90 trabajos en revistas de alto impacto, numerosas editoriales, cartas al editor, y es autor del texto guía por excelencia de anestesia obstétrica. Ha sido autor o coautor de más de 50 capítulos de libros y ha sido protagonista de más de 300 conferencias alrededor del mundo. Yo tuve la suerte de conocer al doctor Chestnut en el año 2006, donde en una conferencia él fue el conferencista principal, digamos, en el Congreso de Anestesia Obstétrica y Perinatológica en Hollywood, Florida, donde tuve también la oportunidad de robarle una foto para la posteridad. Así que, sin detenerlo más, pues tengo el gran honor de dejarlos con el doctor David Chestnut y su conferencia que se llama Professionalism. Dr. Chestnut, please.
Thank you for your warm welcome. This is a great privilege for which I am grateful. I first gave this lecture at the 2016 ASA meeting, and I will give it today almost exactly the same way I gave it just over 4 years ago, with 1 or 2 editorial changes. The title for my lecture was inspired by this book, The Road to Character, written by New York Times columnist David Brooks. Brooks wrote about people who achieved an extraordinary depth of character, people in whom the climb to success surrendered to the struggle to deepen the soul. He described 2 sets of virtues, the resume virtues and the eulogy virtues. The resume virtues are the achievements and skills you bring to the job market and contribute to external success. The eulogy virtues are deeper, the ones that are talked about at your funeral, whether you were kind, brave, honest, or faithful, and what kind of relationships you formed. Most of us would say that the eulogy virtues are more important than the resume virtues, but our culture and educational systems give greater priority to the skills and strategies we need for career success than the qualities we need to develop strong character. A study tracked how frequently words related to moral excellence and virtue appeared in books published over the course of the 20th century. The authors observed a significant decline in the use of general moral terms such as character, virtue, decency, and conscience. They also found a decline in the use of virtue words such as honesty, truthfulness, patience, kindness, humility, modesty, honor, courage, and sacrifice. Meanwhile, many observers have concluded that we have a crisis of professionalism in the practice of medicine. This has not occurred because of a lack of emphasis or effort. Our accreditation and certification bodies all include professionalism as one of the 6 core competencies for physicians. But every definition of professionalism is somewhat subjective. Shakespeare said that professionalism is intangible, and competence in professionalism cannot be guaranteed in the same way as competence in central line placement. The ASA newsletter posed the question, do we know professionalism when we see it? In 2012, the American Board of Medical Specialties defined medical professionalism as a belief system in which group members declare to each other and the public the shared competency standards and ethical values they promise to uphold. ABMS then asked a group of external stakeholders to articulate their expectations regarding physician certification. The stakeholders expressed a desire for an outcomes-oriented assessment of physician performance with an equal focus on all 6 competencies, including professionalism. In other words, the public wants an assessment of a competency that is difficult to define. In this lecture, I will affirm professionalism as a core competency that requires character and lifelong learning, commitment, and practice. And all of us need some help and encouragement along the way. Humility may be the single most desirable professional attribute. David Brooks said that humility is awareness that we are underdogs in the struggle against our own weakness. After completing my anesthesiology residency training, I began my training in obstetrics and gynecology. I was bursting with confidence. In other words, I was arrogant and overbearing. One day, my chief resident grabbed me and said, "Chestnut, the labor nurses hate you, and if you don't change, they will run you out of here." From that day forward, I started saying please and thank you more often. When it was time for me to make a clinical decision, I would often ask the nurses for advice. They taught me a lot. It is true that obstetric nurses are often harshly critical of young physicians, but good relationships with the nurses and other staff are critically important, and good teamwork skills are essential, especially in crisis situations. In this essay, a surgeon emphasized the importance of getting to know the staff. In my judgment, making an effort to learn their names is the single most helpful way to foster mutual respect and collegiality in the operating room and on the labor unit. Few physicians fail because of poor intellect or lack of manual dexterity, but arrogance and pride are self-destructive. Ironically, a person who possesses true humility does not have the slightest idea that she is humble. A humble person recognizes that she is not always right and accepts criticism graciously and gratefully. A humble person acknowledges her mistakes and is quick to apologize when an apology is needed. A humble person does not deliberately call attention to herself. Wise leaders understand this principle, but I learned it the hard way. Shortly after I became chair of anesthesiology at the University of Alabama, I sent my faculty a memorandum with a list of platitudinous slogans and goals for the department. It was ostensibly intended to motivate the faculty, but some of them perceived that it was sanctimonious and self-serving. The next morning, a copy of the memorandum had been slipped under my door. On the copy was this handwritten question: what makes you believe any of us care what you think? Respect is not an entitlement. Respect must be earned. In his book, Good to Great, Jim Collins said that the most successful leaders demonstrate a paradoxical mix of personal humility and professional will. Some leaders display a compelling modesty and are self-effacing and understated. They do not talk about themselves. Rather, they talk freely about the organization and the contributions of others. In other words, they demonstrate servant leadership. I have long believed that career satisfaction is greatest among anesthesiologists who embrace a commitment to servant leadership. As leaders of the perioperative medicine team, we have the unique opportunity to create a collegial and mutually supportive work environment. We can and should affirm and encourage the staff with whom we work. We can learn their names, treat them with respect, and express gratitude for their work. Emotional intelligence and self-awareness are also vitally important. David Brooks said that the people he has deeply admired are profoundly honest about their own weaknesses. In this essay, emotional intelligence and self-awareness were identified as key skills in anesthesiology. The authors affirmed the need for good interpersonal skills in creating emotional and empathetic connections that engender trust and confidence. But self-awareness is not always enough. Several years ago, I was counseling a resident who was having trouble getting along with the nurses. She said, "I am at a disadvantage in this program because all the other female residents are kind and sweet, and I am not sweet." And she wasn't. Not everyone can be sweet, but all of us can and should be kind. Few definitions of physician professionalism include kindness as an essential attribute. But the older I get, the more I value kindness among colleagues and staff. Sadly, a singular focus on career success often erodes a person's kindness. Candidly, I became a more unkind person during my 11 years as a department chair. My wife first called it to my attention when she told me that I was demanding and impatient with servers in restaurants. Over time, my interactions with patients became more impersonal and mechanical. One day, I prepared to perform a pre-anesthetic assessment on a woman who was scheduled to undergo surgery for breast cancer. Her surgeon was in the room talking with her, and so I waited outside the door. I became annoyed when 1 minute stretched into 5 and then 10 minutes. I had other things to do. What were they talking about? But then I realized that the patient was crying, and the surgeon was listening and speaking with an extraordinary empathy that put me to shame. I learned a lesson in kindness from that surgeon. It occurred to me that I had read very little on how we can connect with our patients before surgery. This seemed odd, given the fact that resident applicants often say that they chose anesthesiology because they want to interact with patients at times of great stress. If that is true, then why do so few of us write about it? I want to share a few lessons that I have learned about connecting with my patients before surgery. First, I sit down, and then I confirm that I am pronouncing the patient's name correctly. I then say, "What do you prefer to be called? And may I call you by that name?" I may then say, "Tell me about your name," or "What does your name mean?" I write that name on a note card, and I discipline myself to address the patient by her preferred name from that time forward. When we call a patient dear or sweetie, we are being lazy at best and disrespectful at worst. Second, I typically ask, "Where do you live?" and "Where are you from?" Everyone is from somewhere. Third, I ask the patient what she is looking forward to doing after she recovers from surgery. Fourth, I have changed the way that I complete my assessment. If I say, "Do you have any questions?" that intimidates some patients who are reluctant to admit that they have any questions. And so I now ask, "What questions do you have?" This subtle change seems to make patients more comfortable in asking their questions. Finally, I ask, "What can I do for you right now?" Many patients say, "Nothing." But some patient requests have greatly enriched the interaction. Altogether, these questions add only 2 or 3 minutes to the pre-anesthetic assessment, but they foster the human connection and add joy to my clinical practice. As others have said, it is more important to know the person with a disease than to know what disease a person has. Another important quality is altruism, which may be defined as unselfish concern for the welfare of others. Altruism results in behavior that supersedes self-interest without any expectation of reward. And in some cases, concern for the welfare of another person may involve a risk or cost to ourselves. Carney surveyed anesthesiology educators in Canada to identify desirable professional qualities for anesthesiologists. She was surprised that respondents did not give high priority to altruism. I want to just pause here for a moment and say something that I did not say in my original lecture. And that is that, like many of you, over the last year, I have observed a resurgence in altruism among physicians and other healthcare professionals during the pandemic. And this has been heartwarming to see. But I'll just go back now to the lecture as I gave it at the ASA. On a recent flight, I heard that familiar announcement. Is there a doctor on the plane? Please notify one of the flight attendants. I helped resuscitate a man who appeared to be almost dead. A kind nurse helped me. We did nothing extraordinary. Perhaps the most important thing we did was place him supine, which restored his cerebral perfusion pressure and allowed him to complain of chest pain. We maintained the airway and administered oxygen, aspirin, and supplemental oxygen. At my request, the pilot made an emergency landing, and thankfully, this man did well. Like many of you, I have provided this kind of assistance on several occasions. So I was surprised to read in 2005, a medical professional volunteered to assist in only 20% of in-flight medical emergencies. Do some physicians not respond because of insecurity, fear of litigation, or a desire to avoid inconvenience? Almost 20 years ago, I was attending a medical meeting in Chicago. A group of tattoo artists was holding a meeting at our hotel. Now, in those days, tattoos were not as common as they are today. Some of my physician colleagues made fun of the tattoo artists, who seemed to have a tattoo on every piece of exposed flesh. Now, I did not say anything, but I admit that I had some unkind and judgmental thoughts. That evening, one of my friends asked, "Did you hear what happened outside the hotel this afternoon?" He told me that a man had suffered a cardiac arrest and collapsed, face forward on the sidewalk. His teeth were broken, and his mouth was covered with blood. Several prominent physicians were standing nearby. One physician offered to call for help. A second started chest compressions. But the other physicians stood frozen like statues. No one offered to clear and maintain the blood-covered airway until one of the tattoo artists stepped out of the crowd and said, "I will do it." As Scripture says, people look at the outward appearance, but the Lord looks at the heart. Maintenance of a good heart requires nourishment of the soul. When we discuss professional well-being, we often emphasize a healthy diet, exercise, adequate sleep, and avoiding substance abuse. But personal well-being requires much more than that. A highly respected medical school dean wrote a remarkably candid essay on his own experience. He wrote, "I first met my soul in childhood bedtime stories. I learned that good character arose from faith, hope, and love, achieved through prudence, justice, courage, and temperance. But during medical school, I devalued these lessons. I judged them to be unworthy of study or reflection and superfluous to my professional development. As my career advanced, my humanity languished. I became work-focused, self-centered, prideful, jealous, angry, and resentful. I hit a deep emotional and spiritual bottom as a result of my neglected soul." Osler said, "Engrossed in professional cares, you may find, too late, with your heart given away, that there is no place in your habit-stricken soul for those more gentle influences that make life worth living." My friend Dan Duffy concluded, "In teaching professionalism, we should include the care of the doctor's soul. We should practice social displays of humility and gratitude for the healing miracles that come through our work together. We all need to say thank you more often." Responsibility, accountability, and concern for patient safety are also essential components of physician professionalism. But on my second day of residency training, one of my patients almost suffered a catastrophic outcome. I nearly killed a young man because of a lack of knowledge, poor judgment, lack of vigilance, and inadequate supervision. My staff had performed an axillary block on a healthy young man undergoing hand surgery. As he placed ampules of fentanyl and diazepam in my hand, my staff told me, "Keep him quiet with some of this." I did not see him again. Sometime later, another provider arrived to give me a lunch break. I remember his exact words. "Looks a little blue, doesn't he, chestnut?" If he had not arrived at that moment or soon thereafter, my patient likely would have died, and I would not be giving this lecture. In a 2008 lecture, Alan Santos described a maternal death that resulted from inadequate supervision of a junior resident in his department early in his career. When Alan discussed this case with the department chair, the chair replied, "Think about it, Alan. It probably costs one life to train one resident." All of us would like to think that we are doing better. But not long ago, an anesthesiology resident from a premier department told me that on her first day of training, she was left alone with a patient undergoing prolonged surgery in the prone position. It is not surprising that the rate of medical errors increases when faculty are less than frequently involved in resident supervision. Meanwhile, some of our patients continue to suffer from delayed resuscitation following unintentional subarachnoid block during administration of labor epidural analgesia. Sadly, in some of these recent cases of maternal death, airway resuscitation equipment was not immediately available. We take great pride in the recognition that anesthesiology received in the seminal report on patient safety, published by the Institution of Medicine. Peter Pronovost said, "We have undoubtedly made progress, but the reported numbers likely overestimate how much we have improved because it is difficult to measure safety. We still have much work to do." I want to discuss the importance of lifelong learning in what may seem to be an odd way by telling you my own experience with litigation for a complication of anesthesia. Thankfully, I have had this experience only once. The patient was a 77-year-old woman scheduled for abdominal hysterectomy. Mask ventilation was easy, but intubation was unexpectedly difficult. At laryngoscopy, an experienced provider had a limited view of the glottis. With difficulty, she advanced a stylated endotracheal tube, and we immediately recognized esophageal intubation. We then intubated the trachea with the aid of a bougie. Initial post-anesthesia recovery was uneventful, but on postoperative day 3, her planned discharge was delayed by unexplained fever. Several days later, dysphagia led to the diagnosis of esophageal perforation, and she was taken to the operating room for exploration and drainage of a mediastinal abscess. 3 more times she returned to the operating room. Finally, she was discharged home well on postoperative day 36, and thankfully she suffered no sequelae. I saw this patient every day for 5 weeks. I played an active role in her care. I had a good relationship with her and her husband. A month after discharge, they visited me in my office. But 728 days after the initial surgery, I received a late-night email from our corporate counsel in which she asked, "David, did you know that you have been sued?" Now, those of you who have been sued know what this felt like. It was embarrassing. It was a blow to my self-esteem and self-confidence, and I had recurrent feelings of guilt. Outside consultants agreed that the anesthetic management included no violation of the standard of care. But I thought we might have some vulnerability because of the delayed diagnosis of esophageal perforation. We went through the initial phases of discovery. We obtained the anesthetic record from previous surgery at another hospital, which also described an unexpected, difficult intubation. The plaintiffs then gave their depositions, and I gave mine. 3 days later, the plaintiff's counsel suggested that we engage the services of a mediator. The mediation was both fascinating and successful, and the plaintiffs dropped their lawsuit. Now, I learned some important lessons from this experience. First, how did my apology during the mediation differ from my earlier apologies? I said, I am sorry that this happened. I am sorry that you suffered from this event. And then I said what I would do differently in the future. Second, this experience was another lesson in humility. I had been an anesthesiologist for over 20 years. I thought I was an expert in airway management. I was the department chair. But my understanding of airway injuries and their sequelae was not what it should have been. This review of airway injury acknowledged that prompt diagnosis of esophageal perforation may be difficult, but sometimes we don't know what we don't know. When I last took my maintenance of certification exam a decade ago, I studied for it. I was surprised at what I had forgotten, and I was stunned at what I did not know. Ongoing self-assessment and lifelong learning are hallmarks of medical professionalism. Finally, my case helped me understand the stress that accompanies a bad outcome and the litigation that follows. Consider this anesthesiologist's experience as a second victim. The wall of silence takes a huge toll on the involved caregivers. I was not supported by my colleagues. I had no way to express and deal with my feelings. No one considered the enormous impact it had on me. A survey of the impact of perioperative catastrophes on anesthesiologists revealed that 84% of respondents had been involved in at least one unanticipated patient death or serious patient injury during their career. More than 70% experienced guilt and anxiety. 88% required time to recover emotionally. And 19% said that they had never fully recovered. Martin and Roy said that if vigilance and confidence are reduced as a consequence of depression or acute post-traumatic stress disorder, then patients subsequently anesthetized by the affected anesthesiologist may become third victims. All of us likely have at least one colleague who needs our support today. Any definition of professionalism should include self-regulation. Candidly, we have not done this very well. In this survey, among physicians who had direct personal knowledge of an impaired or incompetent colleague during the previous 3 years, 45% had not reported that physician to relevant authorities. Too often, we have regarded a medical school diploma as a lifetime entitlement, and we struggle to assess competence and fitness for clinical practice, especially in those of us who are aging. An important example of collective self-regulation in the United States is our specialty's response to physician involvement in execution by lethal injection. The lethal injection protocol was described by an anesthesiologist in 1977. Until recently, the protocol typically involved the sequential injection of a barbiturate, pancuronium, and potassium. Lethal injection is now used by all states with the death penalty. The public debate over the use of medicine to perform lethal injection began early. One author wrote that the law turned to medicine to rescue the death penalty. The potential for physician involvement became quickly apparent. Early opposition was voiced by the American Medical Association. Excuse me. But in 2001, 41% of surveyed physicians said that they would be willing to participate in executions. And Gawande wrote about his conversations with several physicians who have done so. Now, why would states ask physicians to participate in lethal injection? In brief, not just anyone can do it. It is often difficult to obtain intravenous access in the condemned. Even preparation and administration of the drugs is challenging. In recent years, United States federal courts have issued orders requiring the participation of an anesthesiologist in the lethal injection. Imagine hearing the following news report of an execution. After multiple attempts, the prison staff were unable to obtain intravenous access. A board-certified anesthesiologist was summoned to the execution chamber. Using sterile technique and sonographic guidance, the anesthesiologist skillfully placed a central venous catheter. He then reassured the condemned that he would remain at his side until he was comfortably and safely dead. A few years ago, my patients often asked, "Are you going to give me the drug that killed Michael Jackson?" I do not want patients to ask if I am going to give the same drugs that another anesthesiologist gave during an execution. Leaders of our specialty wisely concluded that anesthesiologist participation in lethal injection would undermine, erode, and perhaps destroy our patients' confidence in physician anesthesiologists. In 2006, the ASA House of Delegates approved this statement: capital punishment in any form is not the practice of medicine. ASA strongly discourages participation by anesthesiologists in executions. But voluntary professional societies have limited ability to enforce ethical guidelines. So the American Board of Anesthesiology added the following statement to its professional standing policy: an anesthesiologist should not participate in an execution by lethal injection. Violation of this policy is inconsistent with the professional standing criteria required for ABA certification. ABA certificates may be revoked if the ABA determines that a diplomate participates in an execution by lethal injection. Now, the ABA did not take a stand for or against the morality of capital punishment, but the ABA policy represents an endorsement of historic physician professionalism. I was not surprised that some anesthesiologists disagreed with the ABA decision, but I was surprised by the argument that the ABA had overstepped its authority. Some anesthesiologists said that the ABA should limit its jurisdiction to an assessment of competence. But professionalism is one of the 6 core competencies for physicians. Others argued that the ASA, not the ABA, should oversee and enforce standards of professionalism. But enforcing ethical norms presents unique challenges to an organization such as ASA, which has no certification or regulatory function. And expulsion from the society would likely have little or no impact on practice or behavior. The American Board of Medical Specialties requires each of its 24 member boards to assess professionalism. Self-regulation is a hallmark of medical professionalism. The importance of honesty and integrity may seem self-evident, but one of the most vexing contemporary issues for physician certification boards is the protection of examination security and the prevention and detection of cheating on certification exams. In 2010, the American Board of Internal Medicine disciplined 139 physicians who had systematically provided copyrighted test questions to an exam preparation course. 2 years later, CNN reported, for years, doctors taking exams to become board certified in radiology and dermatology have cheated by memorizing copyrighted test questions and creating sophisticated banks of recall questions meticulously compiled by residents from some of the most prestigious programs in the United States. It is well known that this kind of activity is widespread. CNN published comments from program directors and trainees. Some program directors did not think this activity was a problem. Some physicians acknowledged their dishonesty, but they said they needed to know the questions in advance in order to pass the exam. Others accused the certification boards of laziness by not asking all new questions each year. But certification boards recycle between 20 and 50% of test questions from one year to the next because those questions serve as anchor questions that help maintain psychometric validity. Now, I know that certification exams are not perfect assessment tools, but these news reports did not foster public trust in physician honesty and integrity. Our specialty has had its share of bad press. It was a sad day when this issue of anesthesia and analgesia was published in 2011. And recent studies have observed a high frequency of misrepresentation of research and publication activity, as well as plagiarism in personal statements by applicants for residency training. Unprofessional behavior during training is predictive of future disciplinary action by state medical boards. Perhaps it is a short step from application fraud to fraud in patient care. One physician was sentenced to 45 years in prison for giving unneeded or excessive chemotherapy to more than 500 patients. He acknowledged that he had misused his talent because of power and greed. I have a friend who is a retired medical school basic science professor. For many years, he would pose a question to first-year medical students only 6 weeks after they had started medical school. He would ask, "How many of you have already identified a classmate to whom you would never refer a patient?" Invariably, most of the students would raise their hand. Now, why do medical students so quickly identify classmates to whom they would not refer a patient? I suggest that it is not because the students are unimpressed with their classmates' manual dexterity or knowledge of the Krebs cycle. I often ask resident applicants this question: if you could change anything about the medical school admissions process, what would you change? No one has ever told me that greater emphasis should be placed on grades and test scores. Uniformly, the applicants say that greater attention should be given to character, integrity, interpersonal skills, and altruism. But these qualities are often subverted by the so-called hidden curriculum in medical education and the practice of medicine itself. The hidden curriculum includes the cynical attitudes and unprofessional behaviors to which trainees are exposed in the clinical setting, often contradicting and undermining the lofty ideals of medical professionalism. And it likely contributes to the hardening of the heart that often occurs during and after medical training. A few of you may have seen this news story a few years ago. If you did it trouble you? It did me. I suspect that some of our discomfort occurred because at some time in our training or practice, many of us have made a disparaging comment about a patient's weight, personal hygiene, or social history. Or perhaps we have heard a colleague make unkind comments and we were guilty of silence. As one of my colleagues said, this kind of thing happens much more often than we want to admit. Lucy and Suba said that breaches of professionalism occur at every medical center every day, and lapses of professionalism are common, even among highly motivated physicians of good character, especially in complex, stressful situations. Many observers have concluded that we have a crisis of professionalism in modern medicine. In recent years, we have witnessed an explosion in the number of publications on medical professionalism. But it is easier to create codes of professionalism than to change the behavior of individual physicians. And it is unclear whether these statements of professionalism have had a positive impact on the practice of medicine. Recall the ABMS definition of medical professionalism, namely that it is a belief system. A belief in what? Kinghorn wrote, "The various professionalism statements are intended to be consensus statements, acceptable to diverse physicians, and explicit acknowledgement of grounding moral narratives would likely compromise the ability to describe a consensus." But herein lies the dilemma. There is no common consensus or morality intrinsic to modern medical practice in which the professional virtues can be firmly grounded. The professional virtues bloom and grow most fruitfully in the context of the specific grounding traditions that originated and sustained them. Cut off from those traditions, professionalism statements appear arbitrary and burdensome. Cut off from any grounding moral narrative, a statement on professionalism becomes just another set of rules. We may read and process these statements in our head, but they do not warm and soften the heart. Codes and rules do not inspire us to be better doctors and to be better people. So this begs the question, in a culture that values fame and success more than service and sacrifice, how do you make a physician be good? In his book, The Death of Character, James Davison Hunter said that a supportive socio-cultural environment is needed for character and virtue to flourish. He wrote, "Character requires a conviction of truth, abiding within consciousness and life, and reinforced by habits institutionalized within a moral community." David Brooks wrote, "We all need people to tell us when we are wrong, to advise us on how to do right, and to encourage and support and inspire us along the way." I suggest that all of us need help maintaining our moral compass, especially as we balance competing priorities and try to make sound judgments and decisions in the complex, stressful situations that we encounter in modern medical practice. Kinghorn encouraged young physicians to participate in communities of virtue that will allow the professional virtues to be cultivated from within, rather than imposed arbitrarily from without. Personally, I believe that the most solid basis for medical professionalism results from a belief in and accountability to someone infinitely greater than ourselves. But personal character and piety are not enough. In this essay, the author said that professionalism is more than an innate character trait or virtue, and that professionalism requires development of sophisticated competencies that can and must be taught and refined over a lifetime of practice. Consistently exhibiting professionalism is a practiced skill. Professionalism requires lifelong learning and practice. Some time ago, I saw one of my professional mentors for the first time in several years. I asked him, "Do you still practice?" Now, you know the meaning of my question, as did he. But he said, "I no longer need to practice. I already know how to do it." Well, I have not yet arrived at the consistently high level of professionalism to which I aspire. I still need to practice professionalism. I am still on the road to professionalism. Today, I have shared some personal reflections on professionalism in anesthesiology. I have identified attributes that I consider important. humility, servant leadership, self-awareness, kindness, altruism, attention to personal well-being, responsibility and concern for patient safety, lifelong learning, honesty and integrity, and self-regulation. Professionalism requires character, but character alone is not enough. We need others to help and encourage us. And all of us, as physician leaders, all of us help shape the culture of professionalism in our practice environment. Professionalism is not something we learn once, and none of us are perfectly professional at all times in all circumstances. Professionalism is both a commitment and a skill, a competency that we practice over a lifetime. I thank you for this privilege of speaking with you today. I understand that the pandemic is still bad in your country. I thank you for all of the care that you provide for your patients. I thank you for your professionalism, and I wish you all the best. Thank you.
Dr. Chestnut, thank you very much for this tremendous talk. We have lots of attendees. They are doing some questions here that I would like to share with you, and maybe you can give us your knowledge about this. One of them is about how do you assess professionalism in residents? What is fair to expect from young doctors in their learning process, for example?
Well, I thank you for the question, and it is an excellent question, and it is something that is very difficult to do. I think that this starts with all of us as faculty doing a better job of mentoring and modeling professionalism in the way that we conduct ourselves from day to day. But I will admit that as I speak on this subject across the United States, that every place that I speak says that they are struggling with this challenge. And I think that there are some generational differences that make this a challenge. I think that we need to do a better job of teaching the way that our residents interact with patients. We watch our residents give anesthesia. We rarely watch the way that they conduct a pre-anesthetic assessment. And so this is something that we are now doing with professional patients in our simulation center. We are trying to assess professionalism by watching the way that our trainees talk to patients, provide a pre-anesthetic assessment, watch the way that they deliver bad news in the simulation center, and try to coach them in that setting.
Thank you very much. We have another question, but it relates to undergrads right now. With the pandemic, the teaching and all the activities are online. How do you take care of education, online education, and how to assess professionalism in that setting,
Yes.
which is kind of new.
Well, I thank you for the question, and this is a great challenge. I actually teach a course in health systems science in our medical school, and just a few days ago, I was given the task of assessing professionalism in my students, in my medical students, with whom I have had very little personal interaction over the last 15 months, because most of the teaching has been online. And it was a very difficult thing to do. In July, we will welcome a new class of residents to residency training who have had very little face-to-face contact with patients during the latter part of their third year and much of their fourth year of medical school. And so I think none of us really know what to expect, except that we are probably going to have more to do with these new residents than we have had in the past. Now, fortunately, at Vanderbilt, the restrictions have been lifted, and so our medical students are back in the hospital and back doing their rotations as they have done in the past. But I understand that in your country that may not be yet the case. And so I don't have any great answers, except we're going to have a challenge in the years ahead.
Well, I totally agree with you. We have another question here. I think we're going to have 2 or 3 more questions, and I'm going to leave you for tonight. One of our, he used to be a resident with us. He's asking, what do you think about one of the biggest barriers right now is individualism among our colleagues? What's your experience dealing with the individualism among colleagues?
So thank you for the question. Let me see if I understand it correctly. When I think about individualism among colleagues, I think about those colleagues who are reluctant to follow evidence-based guidelines. So I'll give this a try, and you tell me if I'm not answering the question. So I think appropriately in recent years, our specialty and other specialties are placing greater emphasis on using evidence-based guidelines in our day-to-day practice. And yet I have some colleagues who say, oh no, I don't want those guidelines. It takes away from my individual judgment. It takes away from the art of medicine. And I think this is just wrong. And so one of the ways that we are dealing with this in Vanderbilt is that we are sharing with each clinician how well that clinician is adhering to or complying with evidence-based guidelines in the department. Now, right now, we're just sharing that data individually, but I think over time, that information will be made available to the entire department. So hopefully peer pressure will cause all of us to be more compliant with the evidence-based guidelines. Now, am I addressing the question, or did I misunderstand the question?
Yeah, I think you have addressed pretty well. And I would like to ask you one last question. And it refers to your personal experience. One of my colleagues says, I would like to ask you if you remember any situation that has been meaningful in order to achieve what professionalism is.
Well, I gave one example when I was overhearing the conversation between one of our surgeons and a patient who was scheduled to undergo surgery for breast cancer, and hearing the way that that surgeon talked with the patient and listened and was patient and was kind. And it was, for me, a wake-up call that I needed to do better. I'll give another example. When I was at the University of Wisconsin, at graduation, the president of the medical school class said to the graduation ceremony that the most memorable part of his medical school experience was hearing the way a surgeon in my hospital had delivered bad news to a patient and the patient's family. Now, so think about that. The most meaningful experience for that student in medical school was not watching a spectacular surgery. It was not seeing someone make a difficult diagnosis. The most memorable experience for his 4 years of medical school was hearing the way that a surgeon with kindness and empathy delivered bad news to a patient. So I go back to what I said in the lecture. Every year I hear anesthesiology resident applicants tell me, oh, I chose anesthesiology because I like the idea of interacting with patients at times of great stress. And then they get into the program and we don't talk about it anymore. It's not taught. It's not modeled. It's not discussed. For our patients, the way we interact with them is so very important. That's what they will remember about us, is the way we talk to them before a difficult surgery. And so these last 10 years of my professional life have been very meaningful to me because I've given much more thought to this than I did earlier in my career. Earlier in my career, I was more focused on advancement, publications, promotion. And the last decade, I've realized I've begun to think more about, why did I become a doctor? Why did I become a doctor? And one of the reasons that I became a doctor was to be kind, to show compassion to patients who are sick, who face difficulties. I thank you very much for this privilege of being with you tonight.
Dr. Chestnut, this has been very inspiring for us, and I'm very grateful for your talk and for being with us here at Pontificia Universidad Católica and our anesthesia department. So I'm very grateful for your time, and thank you again. I hope to see you soon, hopefully live not through the internet. So thank you again.
Well, thank you again for inviting me. This is a great privilege. And again, my heart goes out to you as you continue to meet the challenge of this terrible pandemic. And we all pray that it will end soon worldwide. Thank you, and God bless you all.
Thank you very much. Bye-bye.